Thank you for your kind introduction. Good afternoon. Congratulations on the start of WATA. And also, I'd like to thank the Professor Xiao for kind invitation. And it's a really great honor. Safety, complications, and quality control from planning to perfection is the key for successful ablation. As we all know, liver ablation is a curative treatment option for early stage HCC. Ablation is no longer an alternative. It is a guideline established curative therapy for early HCC, including BCLC and AASLD and EASL, APASL, and Korean and Chinese guideline. Ablation is already accepted, one of the curative treatment options for early stage HCC. Liver ablation, how to achieve the best outcomes. In other words, how to achieve the safe and complete ablation. I think the balance between safe and complete ablation is very important. First, planning is the half of successful ablation. Safe ablation is achieved not by just avoiding risk, but by anticipating and controlling it. There are so many risks for safe ablation, including coagulopathy, hilar tumor, perivascular tumor, a vessel along the path, periorgan, poor cooperation, poor liver function, and bilioventric anastomosis. After careful selection, we need to correct coagulopathy and using the artificial fluid, and we can apply low power for short ablation time and bipolar mode, or we can choose the non-heat ablation, such as cryo and ILE. And finally, it is important to early detection and management of complication to minimize, to maximize the safe ablation. Complete ablation can be achieved not only by just energy, but also careful strategic planning. There are so many risks for incomplete ablation, including large or small tumor, irregular inconspicuous tumor, and subcapsular, perivascular, and periorgan tumors. We have many solutions. For larger tumor, we can use the more stronger weapon, such as a microwave or multiple RFA. For irregular and inconspicuous tumor, we can apply diffusion or contrast nasal ultrasound. For subcapsular and perivascular tumor, we can apply the microwave or cryo ablation. There are many risks, but we have many solutions. Complete ablation can be achieved not only by the energy, but also careful strategy. Second, check all the details for your successful ablation. There are so many items, from tumor size and number, shape, location, electrode path, ultrasound visibility, and coagulopathy and cooperation, comorbidity, and surgery history. Tumor size and number, tumor shape and irregularity and microvascular invasion, subcapsular or perivascular or periorgan, electrode path, any collaterals along the path, ultrasound visibility, sometimes intercostal space narrowing, perihepatic momentum, coagulopathy, cooperation, hepatic reserve, and comorbidity. Depending on these items, we have to choose the proper energy from microwave to ILE, and we need to decide the number of applicator and exact location, power, and time. And puncture site is also very important. guidance, anesthesia, and patient position. And furthermore, as we all know, multidisciplinary approach is the really smart key for achieving the best result after the ablation. Using the artificial fluid, and we have to decide the purpose of ablation, curative, conservative, or palliative. And sometimes we need to combine with other alternative treatment. Third is the accurate execution, like this. There are 7 principles for perfect liver ablation. First, from never rush the procedure to adapt to real-time feedback, and finally, verify immediately. Let's go over one by one. First, never rush the procedure. Always pause before needle placement, before starting. Make one more look a habit. Speed impresses, but precision cures. Second, respect planned trajectory. Follow the pre-planned path precisely. Even small deviation can compromise the margins. Millimeters of deviation lead to centimeters of failure. Third is maintain the continuous visualization. Use real-time imaging, ultrasound infusion at all times. Avoid blind zones. If we don't see it, we don't control it. Fourth, confirm before ablation. Reconfirm the needle tip position before starting ablation. Ensure proper tumor coverage and tumor ablative margin. Ablation begins only after confirmation. 5. Secure adequate ablative margin. As you all know, minimum 5 mm, ideally 10 mm. Adjust strategy for heat sink or difficult location. We don't ablate just tumor, we ablate margins. 6. Adapt to real-time feedback. Closely monitor echogenic changes and impedance, and respond to patient feedback. Execution is a dynamic, not static. Finally, verify immediately. Perform immediate CT or CUS. Do not hesitate to perform additional ablation. Never finish until perfection is confirmed. What about complication? Early detection and the proper management is important. We should know this kind of broad spectrum after ablation, from bleeding, thermal injury, infarction, infection, pneumo or hemothorax, biliary stricture, CD, myeloma, etc. Bleeding, intrahepatic, peritoneal, intercostal, or hemophilia. From thermal injury to diaphragm, colon, stomach, gallbladder, etc. Infarction, infection, abscess or sepsis or pneumonia, pneumothorax or hemothorax, stricture or myeloma. So compressed for track bleeding and check Doppler, vital sign, and close follow-up, and sometimes we need embolization. We should know the broad spectrum. If you detect early any kind of complication and manage it properly, at least we can avoid the mortality after the ablation. 5 is the ablative margin. As we all know, 5 to 10 millimeter circumferential ablative margin is ideal to achieve the best result after local ablation. So we need to do everything to achieve this kind of circumferential ablative margin. One forgotten secret for main limitation of ablation, our technique for accurate placement of electrode is not so much accurate than we have expected. That's the main problem. There are several challenges to achieve that kind of circumferential ablative margin. First, most index tumor is not truly spherical and not always conspicuous on guiding modality. Second, many more tumor doesn't have the exit for electrode placement beyond the posterior tumor margin. Third, to insert along the exact central axis of tumor is extremely difficult, even expert. The assessment tool to assess the real central placement of electrode on imaging is also very limited. Overlapping ablation with a single applicator is not so much accurate due to worsened sonic window. There are many challenges. We have to overcome this limitation. First, as you can see, most of index tumor is not truly spherical like this, and also not always conspicuous. Many more tumor doesn't have the exit for electrode placement like this beyond posterior tumor margin. For example, subcapsular tumor. And also, to insert along the exact central axis of tumor is extremely difficult. Furthermore, the assessment tool for punctual central placement of electrode is limited. Let me show one case. To overcome the limitation of the difficult central placement of a single electrode, I prefer using this multiple RF electrode, so-called no-touch technique. As you can see, this is better to achieve circumferential ablative margin compared to just using single applicator. Overlapping ablation with a single applicator is not so much accurate due to worsening sonic window, even for the expert. Like this, many more tumors in our practice doesn't have the exit for electrode placement beyond the posterior ablative margin. Just to think about the subcapsular tumor, segment 7. So 2 is better than single. Single ablation with any NOS is not ideal for the tumor without the exit, even using the microwave. Let me show you another case for you. Irregular margin in conspicuous deep located tumor without exit, as well as the peridiaphragmatic tumor. To overcome the limitation of difficult central placement with single electrode, first I use a fusion. I decided to use 3 electrodes. If the tumor size is not so big, but to achieve circumferential ablation, 2 or 3 electrodes is better. The first electrode was inserted along the medial margin of the tumor. Second electrode was inserted along the inferolateral margin of the tumor. Finally, third electrode, superolateral margin of the tumor. I do not insert through the tumor itself, so-called no-touch technique, like this. So after the ablation, track ablation, the the tumor size is just 1.5 centimeter. The ablation zone is 3.5 centimeter. That means 1 centimeter circumferential ablative margin achieved. Finally, learn from your case. I think our case is the best teacher. After the procedure, ask to yourself at least 10 questions. Placement of the electrode was really accurate. Ablation zone is optimal or similar to your plan. Was it excessive? If so, why? Was it insufficient? If so, why? Circumferential ablative margin? If not, why? Any mistake compared to your plan? Any unexpected events? What was the mistake at the planning or procedure? What was the lesson? And then write down what is the well done, what is the badly done, what is the lesson from your case. From these 3 items you can learn. Repeat of well done. Don't repeat the badly done. And finally, please share with your colleague the lesson. Okay, this is my conclusion. As I mentioned before, planning is the real first door for perfect ablation. Thank you for your attention.
It's enough to let it flow, let it be. 'Cause you're